Assalamu alaikum. I am Dr. Maher Al-Asawi, lecturer of obstetric and gynecology, Mansoura University. Today I am going to talk about screening of gynecological malignancies and evidence-based medicine. Let's start by definition of screening. Screening is defined as identification of unrecognized disease in an apparently healthy population. This the whole population appears healthy. One of these have a recognized disease, and if I apply a screening test, I could define this person for further confirmatory test. So this is defined as screening. Screening test should be cheap, should be reliable, should be available to everyone, and should have high sensitivity and specificity. Not all the diseases are suitable for screening test. Some diseases have what is called natural history. What is called the natural history? What is natural history of disease? If we have cervical cancer as an example, this is our current understanding. This is normal cervix. This normal cervix is then infected by human papillomavirus infection. And then human papillomavirus related changes will develop. In about 60% of patients, the disease will regress and return to normal. If the condition is progressed, it will develop into low-grade squamous intraepithelial lesion, or what's called cervical intraepithelial neoplasia grade 1. About 15% will progress into high grade, which is CIN2 and 3. If not treated, it will develop into invasive cancer. So I can pick the disease at any points of this, maybe at the disease of infection, maybe at CIN1, maybe CIN3. If not detected at all, it is invasive cancer. So cancer cervix is one of the diseases that is best to be screened. The WHO recommendation for both the developing and the developed countries has WHO recommended two policies. First policy is screen and treat, and this is suitable for low-income countries such as Egypt, such as Malaysia. They suggest screen your patient and then treat your patient on the same setting. So primary screening followed by treatment, either cryotherapy or loop excision procedure. For the developed countries, they suggest screen and diagnose, but this is long journey, needs well-developed system and a lot of infrastructures and a lot of people. First, screen by cytology or pap smear if your patient is suspicious, followed by referral to colposcopy and then colposcopic guided biopsy, and then treat your patient by either cryotherapy or lead therapy. What is the age group you should start screening of your patient? The age of cervical screening in UK and now all over the world is recommended screening between 25 to 65 years. The frequency of screening should be every 3 years from 25 to 50 years, and then every 5 years up to the age of 65 if your patient is well and good, so your patient will exit the screening program. Why we screen at the age of 25? Why not before 25? As the incidence of infection is very high, all patient in this age is sexually active, so easily catch human papillomavirus, and then human papillomavirus will did some changes which is called human papillomavirus related change. These changes may need further colposcopy and then will burden the system, will cause extra load on the system. So all patient or most of patient will clear the infection without any intervention. So it is best start screening from 25 years. Okay. WHO recommend priority should be given to screening women aged from 30 to 50 years. This is for developing countries, rather than the frequency every 3 years or every 5 years. Screening even once in lifetime would be very beneficial. What is the screening test? There is a lot of screening tests. As we mentioned, the triggering is human papillomavirus, so we can detect human papillomavirus. Human papillomavirus has up to 100 serotypes of human papillomavirus. High-risk human papillomavirus testing, which is human papillomavirus 16 and 18. This is high-risk human papillomavirus and can develop into cancer. The negative predictive value of human papillomavirus testing is very high, as it is a triggering factor. If your patient is testing positive for human papillomavirus, it is merit. It needs colposcopic referral and then colposcopic examination. You can repeat cytology or you can take pathology. This is another screening test, which is via test or pap smear. You can screen your patient by via which is visual inspection after acetic acid. Pap smear, which is in the first world, or Babinicola test. There is a lot of studies that compare the performance of the two tests. If we compare via test with pap smear, the sensitivity is about 84. This is for via test. Via means visual inspection after acetic acid. Visual. I for inspection. A acetic acid. A acetic acid. So this is simple test. What is acetic acid like vinegar? Okay. If we compare to pap smear, which is cytological examination, the sensitivity is 51%. Okay. But what about the specificity? Specificity of pap test is as this is cytological examination. If the test excludes that says so 90% that says is not present. Okay. This is the WHO recommendation decision making flow chart for program manager. Do you have a screening test in your place? Yes, we have 5 tests. Okay. Do you have enough resources to provide HPV test as this is a PCR test? If you don't have, so treat your patient immediately by cryotherapy or leave. يبقى so yes we via test we can apply, and if we don't have extra test so we can go immediately into cryotherapy or leave therapy. In developed countries there is cytology اللي هو pap test, this is pap smear, and then system is well developed so they're followed by colposcopy يبقى number 1 pap smear, number 2 colposcopy, and then biopsy, and then you can treat your patient. Okay, this is a difference between systems. If we compare via screening by HPV screening, use a strategy of screen with via and treat over a strategy of screen followed by cytology, followed by colposcopy, followed by biopsy, and then treatment is best. Screening by via followed immediately by treatment may be best over than the ordinary system. Either one of this is preferred over cytology and treatment. Let's speak about via test. How visual inspection of acetic acid work. Application of 5% acetic acid can cause reversible coagulation of the cellular protein, cause denaturation of protein. So as you see, it will appear white. What is the idea? In malignancy, the number of cells is very high. Cells is very crowded. So a lot of protein. So a lot of denaturated protein. So with malignancy or with dysplasia, acid whiteness will be more, as the white color will be more and more. In normal cervix, there will be just transient acetowhiteness. If you apply acetic acid, then after a while it is just transient and it will disappear. But in malignancy, density of acetic acid, it will be poor. And also a disappearance of acetowhiteness will be take some time. If your patient is suspicious, you should go immediately for treatment, cryotherapy treatment. Who is eligible? If the entire lesion is visible, if you see the entire lesion, entire dysplastic lesion. Squamocolumnar junction is visible, as I will demonstrate what is meant by squamocolumnar junction. If the lesion doesn't cover more than 75% of the ectocervix. If the lesion extends beyond your probe, there is extension into the endocervical canal, so your patient is eligible for excision procedure, which is a LEAP procedure. This is the treatment option. This is the cryotherapy. As you see, this cryotherapy, this is a hand and followed by cone therapy. This cone will be applied into the cervix. This is the cervix. And this is the endocervical canal. So I can apply the loop and I can cryo or destroy by freezing all this area. But what is the disadvantage? You can't take a biopsy for histological examination. Okay, but what is the advantage? It is easy, can be performed without anesthesia, can be performed in the outpatient clinic, and can be performed in the same city. But the probe can't reach this area. So if you have suspicious endocervical canal invasion, so it is you should abandon this procedure and you should go to LEAP. This is the cervix. This LEAP, you can cut by LEAP, excise the whole area. What is the advantage of LEAP? You can take a biopsy for histological examination. You can remove the whole area, including a good part of the endocervical canal. This conization or cold knife like a scalpel. Scalpel. But this is not good method as it will induce bleeding. The procedure is very difficult. This is a comparison between cryotherapy of freezing tissue using a metal cryoprobe. And we can compare into a LEAP, which is loop electrosurgical excision procedure. As you see, the effectiveness is comparable, nearly comparable. The best is LEAP. This is the best. But have advantage in bleeding. May require anesthesia. Cryo is very simple. In outpatient clinic, cold knife is very difficult and require anesthesia. Cryo versus LEAP. If we compare the effectiveness of cryotherapy, the depth of destruction, it's up to 4 mm, and this will eradicate nearly 99% of the disease. However, in a small percent of patients, some gland or extension of the disease will be up to 5 mm and the disease can escape. So LEAP is best in this case. If depth of destruction is inadequate, it may be a source of residual or recurrence. So LEAP is the best. Let's have some picture. This is the normal cervix. This is endocervical canal, as you see. Endocervical canal. This is endocervical canal. Okay, this endocervical canal. This this area is called squamocolumnar junction. Here is squamous epithelium outside, as this shows squamous epithelium. Here is columnar epithelium. This is a squamocolumnar junction. There is what is called transformation zone. What is transformation zone? The transformation zone is the area of transition between purely columnar epithelium to squamous epithelium. So this area is called transition zone, the area between old squamocolumnar junction and the new squamocolumnar junction. What will happen at puberty? There will be a version of the cervix, and the cervix will be exposed to the acidity of the area. So the first area will be exposed. So this was called old squamocolumnar junction, and this is the new area, which is called the transformation zone. This is the area of at which cancer will develop. This is how to report lesion of via test. Should mention name of patient, age of patient, complaint of your patient, and you should draw a picture. This cervix. Where is the area of lesion? Is this area of lesion? You should describe and you should treat if. This is an example of reporting lesion. This is an example of via test. You can see this is the cervix, this is endocervical canal, and this area. What is a? This is a acetoid, but as you see, away from squamocolumnar junction. So this is example of via test negative. Also this area. What is this? This is a last picture on the lower picture on the left side, on the right side. This is a acute infection by gonorrhea. Okay, this is via negative. This other condition, like this is condyloma. What is condyloma? Condyloma, this is a benign wart. اللي هو cervical wart. Cervical warts. Wart. Although you see dense acetoid area, but this is a benign condition. This CIN1. This is the area of squamocolumnar. This is endocervix. As you see, I can see the endocervix. It is appears healthy and clear. And this is acetoidness. What is the best management is cryo. Why cryo is best here as entire lesion is visible? The endocervical canal appears healthy. Okay. This sign to as you see, dense, there is dense acetoidness. I can see the extension of the disease into the cervical canal, so best treated by leap. Leap. You can take the whole biopsy for further confirmation, and if the entire lesion is not removed, so you can refer your patient for further excision or history. This sign 3. Okay. Yes, I think it's very easy. For conclusion, cervical cancer is best screened by, according to your country, UK and European countries prefer cytology as they have infrastructure, they have well-developed system. In our countries, we prefer via test as vinegar is very cheap. You can screen a lot of patients, and it is best to treat your patient at the same sitting as your patient can go away and neglect further management. So it is best treated at the same sitting. Okay. Okay, now we can go to endometrial carcinoma. What is the risk factor for developing endometrial carcinoma? If you look at the figure, you can see each risk factor and what is the relative risk. As you can see, this is the most risky, which is Lynch syndrome, hereditary non-polyposis colorectal cancer. From 22 to 50% lifetime risk to develop endometrial carcinoma. So this is very dangerous. What is also the most common is hyperestrogenemia, unopposed estrogen therapy, like woman taking hormone replacement therapy, like woman taking estrogen without progesterone, or like condition in which there is hyperestrogenemia, like polycystic ovary, like obesity, like diabetes mellitus. An unopposed estrogen therapy, the incidence is from 2 to 10. But what is the risk factor? The highest risk is Lynch syndrome. Okay. This is hereditary non-polyposis colorectal cancer, which is Lynch 2 syndrome. As you see, it is autosomal dominant disease. So, 50% the disease will be transmitted to the new generation of one of parents have the disease, and it will cause 50% lifetime risk to develop endometrial and colorectal cancer. Cancer tends to be in small age, in premenopausal age, and also there is a lifetime risk to develop ovarian cancer. Okay. So to screen or not, although patients of unopposed hyperestrogenemia are at increased risk of endometrial cancer, screening is not recommended. Screening is only based on symptoms. If your patient is 70 years and it was suffered from a condition of hyperestrogenemia like obesity, like polycystic ovary syndrome, but now it is okay, nothing, complaining of nothing. So screening or not screening. Or if she complaining of bleeding, spotting, blood discharge, you should screen. But if not, no screen. Okay. So in general, screening is not recommended except for based on symptoms. This is the presentation of your patient. Your patient, you will ask your patient if there is any symptoms of endometrial cancer like bleeding. Yes, proceed to diagnostic evaluation. If no, no screening, except in patient with Lynch syndrome. This is the recommendation. Annual screening with transvaginal ultrasound, endometrial biopsy, and also colonoscopic examination, and consider hysterectomy and bilateral salpingo-oophorectomy once your patient complete her family. Okay? But for other condition, no screening, no management. But for Lynch syndrome, 50% will develop, so screening is recommended and hysterectomy is recommended. This is if I take biopsy from a patient. Biopsy, this is biopsy result. Biopsy result in postmenopausal patient. This is postmenopausal. What you see? You see in 60 to 8% it is atrophic endometrium, and this will be MCQ question. Most of the most common cause of bleeding in postmenopausal woman is atrophic endometrium. What is the most dangerous is cancer, but as you see, cancer is in only 10% of your patient. This is the next common cause اللي هو hormone patient receiving hormone replacement therapy. Okay. How can I take biopsy from a patient complaining of abnormal uterine bleeding, especially postmenopausal bleeding? Endometrial biopsy. Okay. How can I take biopsy? I can take it as a hysteroscopic guided biopsy, which is the most accurate. As you see the lesion and you take a biopsy from it. You can take a bivalve biopsy, by bivalve. You can take by fractional dilatation and curettage, or by either small experiment like Innovac or something like that. Okay, but what is the first step? This is the first step. In any patient complaining of postmenopausal bleeding, I should do transvaginal ultrasound, followed by biopsy, as I will demonstrate. Transvaginal ultrasound is highly sensitive and specific in predicting the presence of endometrial cancer. Okay, transvaginal should be performed before attempting an endometrial biopsy, as you will disturb the endometrium and cause bleeding, and this bleeding will cause increased thickness of the endometrium. Okay, if an endometrial biopsy has already been taken, an ultrasound should be delayed for 2 weeks. Okay. This algorithm how to treat postmenopausal bleed. History and examination. This is number one. Number two is transvaginal and according. If the endometrial thickness is atrophic, the cutoff point is 4 millimeter. If it is below, if it is below 4 millimeter, it is atrophic endometrium. So what you do? Conservative management. Discharge your patient. Consider vaginal estrogen. If the condition is recurred, this is for outpatient hysteroscopy. If the condition is recurred. Okay. If by transvaginal ultrasound you find thick endometrium, this go for biopsy, either by Bale, either by hysteroscopic biopsy. This is how to manage. As in thick endometrium, there will be a possibility of hyperplasia or cancer. Okay. By transvaginal also, you should, if your patient have adnexal mass and if you see with for further management by CT and MRI. Okay. This is how can I manage thick endometrium and the result is endometrial hyperplasia. If endometrial hyperplasia is due to typical without atipia or with atipia. With atipia, so there is 30% chance to be true malignancy. So you should proceed to hysterectomy plus or minus bilateral salpingophorectomy. If it is just endometrial hyperplasia without atipia, so this is for gestagen therapy if the condition is recurred for hysterectomy. But if your patient suffer from endometrial hyperplasia without atipia, you should have a biopsy every 3 months or 6 months until the condition is resolved. If not resolved, hysterectomy. Okay. So how to follow up a patient of endometrial hyperplasia? In patient with atypical hyperplasia, you should have repeat the biopsy every 3 months. If it is okay, you should repeat every from 6 to 12 months. But at the end, patient should be for hysterectomy. There is no other way. But this is for patient desire to preserve fertility until complete hair family. For patient with endometrial hyperplasia, if your patient is obese, if your patient is not obese and the two consecutive cycle is negative at 6 months interval, then discharge your patient. If your patient is obese, treated with oral progesterone, you should further repeat the sampling and then annual endometrial biopsy and then review if your patient is not improved for history. Now we finish endometrial carcinoma and we can start ovarian cancer. Ovarian cancer is a fatal disease. Average 5-year survival rate is only 30%. So screening and detection of the disease at early stage may be effective and reduce mortality. Ovarian cancer now all over the world, there is many publication and many researches try to define if there is cost effectiveness from screening of ovarian lesion or not. Patient according to age and family history is of ovarian cancer or breast cancer and colon cancer is classified into 3 categories: low, intermediate, and high risk population. Low risk population is the majority of population. There is no family history of ovarian cancer or breast cancer, so this patient is not for screening. There is another category which is intermediate risk, in which there is one first degree relative affected by ovarian cancer but no breast cancer in the family. The lifetime risk to develop ovarian cancer is just 4%. And screening of this patient is now under debate and there is no consensus to screen this population. There is another group which is high risk group in which there is individual history. The same patient suffer from breast cancer. Or there is family history of ovarian cancer or breast cancer and colon cancer in the close relative of this patient. In this patient screening is recommended. But overall, ovarian cancer, although it is a deadly disease, no screening program. or screening test cover the whole population. Why ovarian cancer doesn't have a screening program like cervical cancer? As it doesn't have natural history. Patients suffering from benign ovarian lesion doesn't develop into malignant lesion, so there is no progression of the disease. Malignancy start from the start as malignancy. Benign lesion is still benign lesion. Okay. What is the screening test? There is CA1 to 5. It rise in only 50% of patients with ovarian carcinoma stage 1 and only 90% in stage 2. So not all patients suffering from, with cancer will suffer from high CA1 to 5. Okay. Also, CA1 to 5 is not specific. It can increase in any conditions that can cause irritation of the peritoneum, like appendicitis, like patient even with endometriosis with fibroid can or cause elevated CA1 to 5. So it is good prognostic but not diagnostic. You can screen your patient by ultrasound based by transvaginal ultrasound, but a lot of lesion can mimic ovarian cyst, like inflammatory cyst, like endometriotic cyst, like dermoid cyst. Although this is benign condition or even non-neoplastic condition, but can give appearance of ovarian cyst and maybe suspicious. There is a multi-model. You can combine CA1 to 5 and transvaginal, and then can give you 10 to 15% more accuracy than each test. There is what's called ROCA, which is algorithmic test based on serial CA1 to 5 and age and menopausal test. CA1 to 5 has to perform it as first test, and the TVS is second test. This is algorithm. ROCA test use patient unique, a lot of standard, the same patient, the same family history, the same everything, and CA1 to 5. And we have CA1 to 5 to this patient and to um, compare to patient uniques. Okay. ROCA test may be normal, continue annual CA1 to 5, maybe intermediate risk, repeat CA1 to 5 after 3 months. If high risk patient will start TVS. But overall, you can combine CA1 to 5 and transvaginal ultrasound to have a high sensitivity and specificity. There is two big studies. This is the United Kingdom collaborative trial of ovarian cancer screening showed a significant reduction if you combine TVS and you combine CA1 to 5, which is called the multi-mode. But this trial was carried out in post-menopausal ladies. There is another trial, which is an American study, a prostate, lung, colon cancer, and ovarian cancer screening trial. Use the screening strategy comparing incorporating CA1 to 5 and transvaginal, but didn't show any benefit regarding mortality reduction. So up till now, there is no screening test or screening program for the whole population, but it is advised for high risk population to do CA1 to 5 or and transvaginal. So at the end, to reach a conclusion, for cancer cervix, screen and treat with via test, followed by cryotherapy and rape. Screen and treat immediately. Up till now, for endometrial carcinoma, there is no screening test. But screening is based on symptomatology. Apart from Lynch syndrome, which is very high risk to develop endometrial carcinoma, so it's better to do hysterectomy and endometrial screening until hysterectomy. For ovarian cancer, no screening test apart from high risk population, and the screening test is CA1 to 5 and transvaginal ultrasound. Thank you so much.